listening to Table for Five with Felicia and Annette, only on LA Talk Radio.
Good Monday morning.
Good morning.
Good morning, everyone. Welcome this morning. Welcome to Table for Five.
Yes, we're having a good show today.
Yes, we are. Today is Monday, June 11th.
All savvy with your electronics.
Well, yes, I'm
today?
trying to because my printer did not work.
Okay. I was like, wow,
So we had some technical difficulties. It's summertime.
Wow.
We're like laid back,
Is that
and
right?
all of the
Okay.
electronics and everything in my house are
not
laid back.
working?
Yeah, everybody's
Okay.
laid back and everything
Well, I got
is
my
laid
paper.
back. I have my phone.
She got my paper.
Today is Monday. It's Monday, and you are viewing and watching
Yes,
Table for
yes,
Five
you
with
are.
Felicia and Annette. I'm Felicia.
I'm Annette.
And we would love for you to join us every Monday here from 11 a.m. to 12 p.m. Pacific Standard Time. Welcome to Table for Five. Again, I said that already five times. My mind is a little going everywhere because of
from
summer.
Your whole weekend and
No, and I was a little rushed. But let me finish the intro. Where you,
that part,
the listening and viewing audience, will always have a seat here at our table Mondays, 11 a.m. to 12 p.m.
and
Central Standard Time.
Yeah, get your PST in there.
Yes.
And we want to also remind you, as always, how to connect with us during the week. And you could go to our social media platforms, which is Table for Five on Twitter, on Instagram, on Twitter, Instagram, and then our Facebook is Table for Five at Felicia and Annette. And what I like to call our one-stop shop is our website, which is table-for-FOR-5.com. And there you can catch up on all our previous shows. You can find out a little bit about us, where we've been, what we're doing, what's coming up. And also, if you've missed any shows, I said that already, but I know, see, we're repeating ourselves.
Yes, that's okay.
Is that kind of Monday? You can go on, if you have a product or something that you want to promote, there's an Advertise With Us tab on there, and you are welcome to go and read all the different tiers that are available, and then someone very professional will get back to you with information and pricing. Isn't that great?
Yes.
So you would be,
Yes.
That's it. So that's all our social media. And again, if you want to join in this very important conversation we're having today, which is on men's health and health in general, you can call in at 818-570-5085, 818-570-5085. And if not, we're live right now on Facebook. You could just hit us up on Facebook. If you don't want to talk on the phone, you could just send your question via Facebook Live and let us know what you want to know about our special guest, Dr. Kelly.
Yes, it's going to be a great show today.
Yes.
This is June.
It's perfect.
June, there's a lot of stuff going on in June.
Yeah.
This is,
Graduations.
graduations, Father's Day. Today is going to be about men's health and just health in general, but kind of focusing a little bit on men's health because I think it's very important, with Father's Day being in June, and, we don't give our male counterparts, so much attention when it comes to the health department sometimes. And so I want to promote that and get that out there. And I think June is it Men's
Health Awareness Month. Did you know that?
I did not.
That's okay.
Not until you asked me to come on the show.
No. Listen, our trusty associate producer, thank you, Nareda, who was doing research, found this out for us, and I didn't know that. We didn't know it when we were preparing for the show either. So that was
works out fantastically.
I need to know. So that worked out really well.
But before we jump into the show, the topic of the show, we want to get into some hot topics, some things that happened. My week was a little crazy. I'm coming down off of like a emotional roller coaster. My oldest son graduated from 8th grade. It was very emotional.
Shout out to Dominic.
I know. In his school, Legacy Christian Academy, they put on a beautifully emotional graduation.
Yes.
Thanks for all of that. I knew I was in trouble when I walked in, and there was a tissue box on the end
aisle.
of the
Every
aisle.
I mean,
was
what
like,
setup is that?
These people are coming. They're serious. They're
coming for your emotions.
Yes, and they did.
Yeah,
They
she was
very
crying.
much did.
It was like this.
Yes, I was doing the shaking the
She
shoulders
was shaking
cry.
the shoulders cry. I was like,
It
is
was-
she crying that hard?
Yes, it was
What is she
pretty
going to do
bad.
in high school?
Oh,
College?
it's gonna be. I'll be on the floor. I'll be on the floor crying. So yes, it was emotional. We had lots of family in town. Everybody left yesterday in a wave. They come and go fast and whatever. So yeah, lots of people and just coming off of that. So I want to say congratulations to him. And it made it a little extra special because I was class of 1988 when I graduated from elementary school. Shout out to all my St. Anthony of Padua friends out there on Facebook.
Okay.
Class of 88. Yes. Listen, we're a tight group. Y'all just don't be knowing. And so my son is class of 2018. So it was exactly 30 years later. I mean, it just gives me chills.
Mention about your mom.
Oh,
and,
yes.
Yeah, that
And
was
so
really cool.
my mom flew in, and my best friend's mother was there. And it was very interesting because I was like, oh my God, you guys were together 30 years ago around this time of year, graduating her daughter and myself, best friends from elementary school. And so it just made it like a little extra special and a little extra emotional.
Yeah, it just added a little
Everything
more
was
to
extra,
hysteria.
extra.
She was hysterical.
Yes,
she was.
Yes. So shout out to that and all the family and everything, and just a great time. And congratulations to all the graduates.
Yes,
Elementary
yes.
school, high school, middle school, whatever you're graduating
Med
from.
school.
Kindergarten,
Med school,
graduate
yes, Lord Jesus,
courses,
med
masters.
school.
What job well done to everybody, because
Yeah.
it's not easy. Academics,
Nowadays.
it's no joke. So and if you're
Competition
going
is
into
fierce.
yes.
Well, I just had a quick. My son did his piano recital.
I saw that. It was
And
beautiful.
he played two very, very interesting, difficult pieces, and he nailed them both, and I was very proud of him. So shout out to Paul Mata for
Yes.
doing the most, and for Piano Playing Music School Systems in Sherman Oaks, Pasadena, and Woodland
Wonderful.
Hills, for just having an amazing program for students, young and adults as well. They're all ages, and for
Yeah.
putting on, they had about 8 recitals that day.
Oh wow.
Yeah, it was crazy, but it was great. It's always so good to see the kids, progress, because
Yes.
I love how they plan it where the younger kids play the piano, and then as you see the progression, and then the older kids who really play really well play at the end. So it's very sweet to see that progression.
I
of
love
what
piano
the
play.
potential. Yeah.
The kids did it when they were very young. I love them because they have classes for very young kids.
Yes. My oldest started taking lessons there at 18 months.
Yes,
And
18
Paulie
months.
started taking lessons there at 22.
18 months.
18 months. Yes.
Listen,
Yes.
I was in there. I was like, we got to find something for y'all to do because you are running around. And I found Piano Play,
Yeah.
and they were just great.
They have an incredible
Yeah.
children, toddler program. I mean, it's amazing. It's amazing. So Paul started at 22 months, Rob started at 18 months, and Rob went all the way through senior year in high school, and Paulie's been in it still and doing really well. So
and
we're
will
very proud.
continue to be. So.
Yeah, until senior year in high school. That's a non-negotiable in my house. You want to stop doing something except piano. Yeah. So anyway, that was our weekend.
Yes, and then so some other hot topics that I really want to talk about
Yeah.
too is the untimely and unexpected deaths of 2 very creative people
Yes.
this week that I was very saddened by. Kate Spade and Anthony Bourdain. If you don't know who Anthony Bourdain is, I know some people do. So I love food.
Yeah.
I love to eat. I love the experience of it. I love everything about it. It's great. And so Anthony, I've been following him for a long time.
Yeah.
I've been a Food Network fan, and then he went on and he had a show
Travel
recently
Channel.
on C, and
Yeah.
it was
And
Travel
then
Channel or CNN?
He went from Food Network Travel Channel to CNN.
Yeah. And just an amazing, always had amazing shows.
Yeah.
And I loved that he mixed food with the culture.
Yeah.
He was always very respectful and always very mindful to talk about more than just the food restaurants and, stuff like that and mainstream stuff. He really got in and talked about stuff. He did a piece on Puerto Rico right before we came back or left or something. It was before the hurricane.
Yeah.
And I thought it was just amazing.
It was after the hurricane, I think.
It aired after the hurricane,
Oh,
but
it
he
aired,
went. But he
okay.
went before,
Okay.
and taped it. So he was just a creative soul, and and both of them suicide.
Yeah.
Do we know why? I still have. I've been so busy to find out what and why Anthony Bourdain. Did
I don't
anybody
think
read?
they
I've just
said
been reading
much about
tributes.
that.
So it's interesting because the incidence of suicide is increasing across America.
Really?
Oh, yeah, there's like great evidence. A lot of the evidence is from 1999 to 2016, I think. And there's literally a map if you go on the CDC website, and every state, it'll give you like the rate of how much suicide has increased in every state.
Do we know why that is?
Well, suicide is kind of like multifactorial. There's a lot of risk. But I think one of the interesting things that I read about suicide was that 54% of people who committed suicide had no known mental illness. So that kind of speaks to, what's Bourdain? What's his name?
Anthony
Anthony
Bourdain.
Bourdain.
That kind of speaks to him because a lot of people were saying that they thought he was happy,
Right.
didn't know he had any mental health issues, and there's a lot of people who don't have mental health issues and they commit suicide.
Or do you
And
think it's undiagnosed? mental
it could be
health issues?
undiagnosed. I mean, a lot of people have subclinical depression, but you don't necessarily have to have depression or mental illness. Sometimes there's just factors in life, like
I feel like we kind of saw it with Bourdain, though. Like, really? I feel like in some of his shows, he was always a very kind of a dark soul.
Yeah. Well, he was a recovering alcoholic and a recovering heroin addict.
Yeah.
So that is one of the major risk factors for suicide is substance abuse, and specifically for white males, alcoholism.
Wow.
And white middle-aged males have the highest, incidence of suicide, and it's growing a lot more than any other age group. So
and alcoholism and drug abuse, I feel like, stem from a mental health issue because you're self-medicating for something. And so I think that makes sense that, I just feel like we don't take mental health seriously in this country at all. And it needs to start at a younger age. I mean, I would love for people to go out and get help, yes, in their 20s and 30s too, but I think we're seeing it in our teenagers and the, instances of school shootings and bullying and stuff like that. And I think if we get a hold of it sooner, then it won't manifest and fester for these young people.
I mean, from a medical perspective point of view, I do think that you're right. Even though we're seeing the school shootings, a lot of kids suffering from bullying and they're, suicidal or depressed, they still have lower risk of suicide than, their middle age or higher age range counterparts. But there is a problem with handling depression, suicide, drug abuse, a lot of mental illness. There's a strain on the healthcare system, and specifically working in LA. LA has a huge homeless population, huge, and a lot of those people have mental illness. And then also, I'm an ER physician, so I see a lot of kids that come in who are suicidal. They're cutting, they're doing a lot of things, and their parents don't know what to do. They have some counselors, but I just think that, like any part of medicine right now, we just don't have enough providers to kind of handle what's going on. The CDC is putting together what they call it it's like a strategic approach to trying to address this issue. So they're like putting out a lot of information on how we can help with like preventing suicide, what people can do, how you can help people have suicide. I should have probably bought the website.
No. They can look it up.
I do want to get this number out since we're talking about it. Suicide Prevention National Lifeline. It'll be on our Facebook Live in a minute. It's 1-800-273-TALK. 1-800-273-TALK, and TALK is 8255, the Suicide Prevention National Hotline. Yes. Hey, before we continue this conversation, let's formally introduce Dr. Amanda Kelly.
Yes.
I'm just going to read her bio because it's just so impressive, because she's so young and so smart. But Dr. Amanda Kelly, Dr. Kelly is a board-certified emergency medicine physician. She has been educated and trained in New Jersey and Philadelphia. Dr. Kelly is a proud alumni of Rutgers University in New Jersey. You know that my gynecologist, OBGYN, who I love, Dr. Rabin. Yes, he's an alumni of Rutgers.
Because we're stellar.
Because you're stellar. Yeah, he's stellar. I love Dr. Rabin.
He's special.
African American?
No, he's Jewish.
Jewish? Oh, no, because Rutgers, I'm just giving them a little shout out. They have a great program called Office of Diversity and Success in the Sciences, and it's geared toward helping minorities, Hispanic, African American, or anybody kind of underserved in medicine get into the medical fields. And they've produced a lot of doctors and dentists. So if your kids are kind of on the East Coast, they want to go, you should go there.
Or even here, right?
Yeah, that's what I'm saying. If they want to go to school
from
on the East
there,
Coast.
from here to there. Upon completing her medical education at New Jersey Medical School in Newark, New Jersey, she went on to complete her emergency medicine residency training at Albert Einstein Medical Center in Philadelphia, Pennsylvania.
Not the one in New York.
I was just going to say, because my sister had her kids at Albert Einstein. Dr. Kelly currently practices at Northridge Hospital Medical Center, caring for the community of the San Fernando Valley. Northridge Hospital is a level 2 trauma center which opens its ER doors to both adult and pediatric patients. Though Dr. Kelly's primary job is to practice clinical medicine, she is very passionate about empowering and educating patients and people in the community to foster better patient-doctor relationships. She firmly believes the best care is achieved when both patient and doctors trust and understand each other. So welcome Dr. Amanda Kelly to our show. Yay! We're going to give you a little applause.
You guys can hear. You have your ears.
You can. We don't have our inner ears
no,
on. So
I didn't want that.
But so yeah, we wanted to talk to Dr. Kelly.
More applause. Thank you.
Yeah, you're just running this.
I don't know why all of this is happening.
Now we got crickets.
Yeah, it's just going by itself.
Can we pause it? Okay, can we shut these cryptids
I
down?
don't know what's happening. I don't know why it's not going
This
on.
is technology at its
Yes.
best.
At
It
its
stopped.
finest.
It
Yeah,
stopped.
it's
It's
done.
good. Yes.
It's good. Just had to run its course,
I know,
I
we
guess.
just had to play it all for her. We had to play
Sound
it all,
effects.
play all the music,
That
play
was
all the
good.
sound effects with Dr. Kelly.
Yes.
But it was so great that, look at Mark laughing out loud. Hello. Mark,
Oh,
stop playing.
Thanks, honey. You're great.
The timing of this show, it just so, was,
Yes.
we wanted to do the show, and then the suicides happened. So we
Yes.
thought, wow, this is a great time to have this conversation, especially the interesting, a man committed suicide and a woman committed
Yeah,
suicide.
and Kate
so,
Spade.
yeah, so both, we had both genders. It wasn't like, oh, only women commit suicide or whatever. But I
Right.
read somewhere, and I don't know if you just said it, was that men are committing suicide more.
Yeah, so there's a such thing as a gender paradox in the land of suicide. So women, even though they contemplate it more and they have more suicide attempts, they don't actually successfully carry out. And I hate to use the word successful with suicide, but
Right,
they don't.
right.
And a lot of research has been done into that, and we think that it's because men tend to use more violent or forms of suicide that will immediately harm them. So hanging, firearms, or some guys will use like carbon monoxide. So like maybe sit in a car with the garage with your car on, things like that. Women are more likely to use pills or overdose, and so those things are harmful. But oftentimes people will find you before
Right.
you actually die from those things. So that's why men tend to have higher rates, even though women have more attempts.
Interesting. Very interesting. Now, how did Anthony?
I
think
think
he
they
hung
said he
himself.
hung himself.
He hung
Oh,
himself.
wow, so
But also
both.
Kate Spade too. I think.
Yes.
she hung
So
herself
I mean,
as well.
it's kind of interesting that they both hung themselves because those are both pretty lethal forms of suicide. But I also, as a physician, I've seen women shoot themselves too. So and so it's like it's not a hard and fast rule because women do complete it. But
Right.
I will say that I definitely do see more patients, overdosing
In the ER.
in the ER, and those are more likely
Women.
women.
Okay,
Yeah.
so we're
And they
gonna-
both had children. They both
yes,
had families.
they both had kids.
So
She had
it
a
has
they
to be
both
a
have
lot.
one daughter.
Yeah.
But from what, like you said Anthony Bourdain suffered from alcoholism, and then Kate Spade, I read somewhere,
She was
suffered from
depression, yes.
So,
So there
you
were
know.
underlying conditions, but it's so I don't know. I'm not criticizing them. I'm not making a judgment on any one of them because I know to make that decision is just such a desperate decision. But in my mind, I'm thinking, in that moment, don't you think of your kids? Don't you think the child you're going to leave behind?
I don't
the
think they think of
scar?
anything.
Yeah,
I just
you
don't
don't
think
really
that.
I think
of-
sometimes you just get into such a dark place. Usually having a family and having kids is protective. It's one of the things that, psychiatrists and people evaluating people who are suicidal take into consideration when they consider their risk. So it usually is protective when you do have kids or, it makes you not do it. But I mean, sometimes you just get into such a space where it doesn't matter.
Yeah, and it's and maybe it's been contemplated for a while, and it's
Right.
been put off because you have children,
Right.
and then it's just like you can't take it anymore.
Right.
So it's a shout out to. I mean, our thoughts and prayers are with their families because this is just
Absolutely.
an awful time, and it's one thing to suffer the loss of a parent or family member, but when it happens, through suicide, I feel like it's a little bit more devastating. And so, our thoughts and prayers are with both families.
Absolutely.
I also think that it'd be important for just people in general to kind of maybe find programs or things to help them recognize, depression, to kind of help their family members and their friends, because oftentimes you hear friends or family say, "I just didn't know, I had no idea,"
Yeah. Right.
and
We
it's-
don't talk about it
Right,
because
right.
we're embarrassed.
especially minorities.
Yeah.
Mental illness is not something that's, yay, you're
Yeah.
depressed, or yay.
Yeah.
It's
Yeah,
things
or
that
hey,
people
I'm
don't
going
talk
to the
about.
therapist. Yes,
Right.
you should go to the
Yeah.
therapist. It's
Right.
not
It's
supported.
very taboo.
Yes,
Very taboo.
Talk
Very
therapy.
much
I
so.
don't know why. Listen, I don't know why everybody is not in talk therapy. I think everybody.
Talk therapy?
Yes,
This
talk
is what we
therapy.
do
That's
here every
underutilized.
Monday.
Yeah, but that's underutilized. I mean, talk
Yes.
therapy, I think, probably evolved from I forgot what type of psychotherapy it is. But a lot of times, psychiatrists now, they're overwhelmed, so they don't always have the time to just talk. So
Right.
you have to find the correct therapist for you, probably
Right.
more a psychologist or a therapist than, in addition to, medications from
Listen,
a
I was looking
psychiatrist.
for a therapist, in full disclosure, and a couple of weeks ago, I called 5 and they were all booked.
They-
Like
not
they
taking
were
new
all,
patients.
they were
Exactly.
not. They were so full because they
Yes.
just couldn't take any more patients. I
My
was
friend
like,
had a
oh my
similar
Lord.
experience, and then if you even want to get specific, like I only want a female or I only want an
Oh,
African
no, I
American.
didn't
like,
care. I just wanted a.
No, I'm just saying.
Yeah.
Like, but then
Oh,
if you
yeah.
have like anything,
it's
that,
even
that
more
just-
limited.
It's way more limited.
It's very
It's
interesting.
tough, even when
Why
you have
is
good
that?
insurance.
Is that
it's
everybody?
tough.
Yes. I mean,
Yes.
is it because everybody's in therapy, or is it because there aren't enough?
I think there
Physicians are
aren't that
overwhelmed.
many. Yeah, I don't think that there are enough therapists, and I think people are getting the message now that it's better to go and seek out help and seek out therapy. And so I think the therapists that are out there are probably being bombarded, and really great ones, people don't like to let go of them.
Right. Right.
Because if you have a good one, you're kind of like, well, I have a good therapist, but it's kind of like a nanny like,
Yeah,
or a
you find
babysitter.
it-
You're like, well, I have a good one, but I'm not sharing it with you because
I
then
had
you're
a-
going to take them.
I had an interesting conversation with a friend of mine who's has had a therapist for a while, and she said the therapist said, "I think you can move on without me," and she's like, "No, I can't." She
I
says,
need
"No,
you."
really." So she stopped seeing her on a regular instead of every week. She sees her like twice a month. Like
Yeah.
the therapist is literally weaning her off of
Yeah.
coming every week.
Yeah. Yeah.
I was like, girl, leave her, let her come, give me room. Let me have a spot to go. Okay, so we want to address men's health. And
Yes.
one of the pieces that came out recently out in the news is
Colon cancer,
colorectal
colorectal cancer.
cancer screenings.
and that's changed.
That's changed
Yeah.
the age.
So there are a couple of task force or societies that give recommendations for preventative care. Colon cancer falls under a disease or clinical illness that you can screen for. So the organization that changed their recommendation is the American Cancer Society.
Oh, it was the American Cancer Society.
Yes.
Okay.
So I think that they changed their recommendation because there's some studies that are coming out that show that the incidence of colorectal cancer for people under 50 is actually increasing, though the
interesting.
rates of colon cancer in general in the United States has been decreasing. So because of that, they changed their recommendation to get screening to the age of 45 instead of 50.
Now, is there a reason why that is?
Why it's increasing among younger people?
Yeah.
I have not found the answer to that. I don't know.
Is
But
it their
I've seen it. But
behavior?
I've
Is
seen
it
it
their
myself.
diet? Is
I
it-
mean, it's probably related to diet. I can't like 100% for sure say. I'm not a GI doctor, and I
Right.
haven't read anything myself to answer that question. So
Right.
the answer is I don't know myself. I don't know.
Yeah, because
why
I
it's
find that
increasing.
fascinating. That what is it in their behavior that's changed,
But-
or is it their? It has to be. I
I
would
think
say
if we're
diet.
recommending to screen earlier, then we're finding it earlier. So I think maybe hopefully people are grabbing onto their health a little bit more, and the younger generation
So I
are
feel like
going
with,
to
with
look.
cancer, it's interesting. Anytime like younger people get cancer, it tends to be more aggressive, or it's really late when you find it. So these young people who are getting cancer, like they're already symptomatic from their colon cancer, meaning they have belly pain, they have like blood in their stool, or it's already spread. So, and I've seen it. Like I actually started to see it when I was in residency. I've seen like 30-year-olds like with metastatic colon cancer, and I'm like, whoa. So it's not like shocking to me that they're changing some of those recommendations, at least the American Cancer Society. But there's a few other organizations that, so there's like the U.S. Preventative Task Force, American College of Physicians, American College of Gastroenterology. They all kind of still have their recommendations as starting at age 50.
50.
So the some of the screening, so you have like colonoscopy. I think everybody knows what that is. It's a,
Right.
it's a camera. You have to kind of cleanse yourself. So you drink a little nasty fluid and you get all the stool out, and then they basically stick a camera through your entire colon. And then there's like flexible sigmoidoscopy, where it's the same thing, except that they don't go through your whole colon. They kind of just go through your descending colon, which is more on the left side. So it's your rectum, and then your sigmoid colon, and then your descending colon. So you kind of miss the whole right side and upper part of your
And why would you do
colon.
that instead of the full
Colonoscopy.
colon?
I mean, the standard is a colonoscopy.
Right.
Some people just don't want to do the colonoscopy, or but there's other things.
Yeah, I
you
was
can
gonna
do.
say, there's alternatives, right?
So yeah, so there's
'Cause
other
I'm
screening
I'm past
modalities.
50 and I refuse to do
Listen,
colonoscopy.
you
Well, I
could-
don't think that's
could-
very smart.
I
but-
know.
But there's other
Tell her,
things.
physician, tell her.
There's a lot of advances in medicine. So there's like CT colonography. That would be recommended every 5 years instead of every 10 years. And CT colonography is basically they shoot a little air into your rectum, and then they use a CAT scanner to shoot some images, and they kind of create either a 2D or a 3D image of the colon, and that kind of can help you identify any polyps, any suspicious lesions, any narrowing, anything like that. But there are some, benefits to that. It's non-invasive. There's some disadvantages if you don't complete, the cleansing part. You still have to kind of, get all the stool out. And then the benefits to that is sometimes when you have cancer, there's obstructions. So you can't, even if you do a colonoscopy, you can't get through the point where there's an obstruction, so you can't see the whole colon. But with the CT colonography, you can. So, I mean, there's some advantages to that. Double contrast barium enema, that's kind of fallen out of favor, but they shoot air and contrast into the rectum, and they shoot a an abdominal x-ray, and you can kind of see all the dye and see if there's any lesions or anything
Does
like
the
that.
dye though go all the way up? Does it go through the whole entire colon?
I think it does. I'm not 100% sure. And
I'm
then
liking that
there's some
colonography.
other type of things. You should do a colonoscopy. They can give you medications. Like it's not.
Listen,
It's not.
I don't like going under anesthesia. I don't like doing.
But it doesn't have to be. It's not. It doesn't have to be like general anesthesia.
Yeah.
It's just a little sedation. Most people are awake.
I don't like sedation either.
Would you rather die from colon cancer?
I would
That
not.
is the
No.
alternative.
I would not. But what about? Isn't there a pill that you can take that you swallow with a
that's,
camera, and then that
yeah.
goes through the whole entire colon?
Yeah.
I really like that.
Can we do
alternative.
that?
What you can access?
Can I do that instead?
You
I
just
mean,
you
don't-
take it orally. I feel
Yeah,
like if you do
it's called like pill
both of them.
endoscopy. Or
Yeah.
whatever. I think
Maybe you could
that's
do
what
that
you're-
one
that's
and
what
then
it-
do the-
That's what you're referring to. But these are things that, again, why you have to have a good primary care doctor or a GI doctor, because these are probably more specific questions that they can answer because they do this day in
Yeah,
and day
she's
out.
waiting for me.
So yeah, exactly. But then there's other things that you can do that are more frequent, like annually. So like fecal occult blood testing, and then
okay. So
that's
they
the
can do
famous
fecal
testing.
testing.
Yeah, I mean,
Yes.
we do that in the ER all the time. So
Yeah.
there's fecal occult blood testing using like guaiac, and then there's like hold on, let me look it up.
So what is you take the feces and you spread
Yeah.
it and then you test
So,
it, right?
Yeah, so you do a little.
Okay, well, you're
you
not
do-
doing it.
you
No,
do-
but I've had to do that for just a physical.
I can't tell you how many times I do it in the emergency department every shift. It's great.
gosh.
So why
she's
are
a
you
doctor.
doing these in the ER? Isn't this
So a lot
something
of
that should be done annually?
So, well,
Let's talk about
how
ER
people
medicine.
utilize their emergency department.
Yes.
Oh.
You know, it's interesting. You know, I'm a trained emergency medicine doctor, so we're trained to handle the worst of the worst emergencies. However, people come to their emergency department for things that can probably be better handled by their primary care doctor. So rectal
Yes.
bleeding, they come for. And I mean, if you're gushing blood out of your rectum, then yeah, absolutely come.
Yes.
But some people be like, oh, I see like a little blood, and sometimes you can wait and go to your primary care doctor. But for those type of patients that present that way, we do a digital rectal exam, and then we do a little guaiac, take a little smear, and you put a little solution on it to see if there's any what we call occult blood or blood that you can't see with your eye. Typically, if you have that, then it's like, oh, you should follow with your primary care doctor and get a referral to a GI doctor to assess if you have any risk for cancer, because there's other things besides cancer that can cause GI bleeding. Sometimes you'll have internal hemorrhoids. Sometimes you can just have constipation, and then you get little tears because you're pushing out hard stool. I mean, there's a lot of benign things that can cause rectal bleeding.
And really, fresh blood is not as alarming as people think, correct? You're more concerned about the dried blood or the darker blood or really black stool. That means it's more internal.
So the color of the blood sometimes can indicate whether it's an upper GI bleed or a lower GI bleed. Typically, lower GI bleeds, it's the brighter blood. The upper ones, it's darker blood because it's oxidized or it's kind of mixed in with oxygen, so it's a little darker. But sometimes you can be vomiting blood and it's going through your system so quickly you'll get red blood through your rectum. So I mean, there's a lot of things to consider in the picture.
And I want to ask you something about that. Now, do you think that sometimes people come into the ER for something what we would consider maybe a simple issue because you're going to get your results a little bit more faster? Say you go into your doctor, your primary care doctor, they're going to run these tests, but my beef with going through primary care doctor is that your labs, it takes forever. And so do you think that sometimes people do that? And I don't think that they
Absolutely
should.
no people do that. Absolutely. Like,
Because when you're in
like,
the ER, it
so
comes fast.
A lot of people like to think that, oh, people use the emergency department because they don't have insurance. That's not true. That is absolutely not true. Studies show that people who have insurance will utilize their emergency department because A, they can't get an appointment with their doctor. It's like, I can't get in fast enough, so I'm going to come see you to make sure I'm not dying.
Right.
So that's really,
Wow.
that's really what it is.
Yeah.
And, you know, like, honestly, going through, I remember I had an attending when I was a resident. An attending is a physician who's already completed residency. So I used to get frustrated, like, God, like, I don't understand, like, why is this patient here? They could have went to their doctor. Or the classic, my kid has a fever, it's 2 a.m, I didn't give them any Tylenol or ibuprofen, but I'm gonna come to the emergency department. I used to get so frustrated. And my attending pulled me to the side. She goes, listen, people don't know. They just, they
They
think
don't.
it,
They really
think it's
don't.
an emergency, and your job is to answer, you're okay. So, I mean, we're always happy to see you. Our doors are open. I think the most important thing when you come through those doors, though, just be honest about your symptoms. Sometimes people will play up their symptoms thinking that they're going to get care faster. It honestly just confuses the ER doctor, because my job is to make sure you have nothing life-threatening. So if you play up your symptoms, or you make it more than what it is, sometimes you get testing that you don't need, and those things come with risk. Radiation with CAT scans, things like that. I mean, do you want cancer later? That's what so those type of things.
That's
Right.
interesting. Well, go ahead.
I was just gonna say, I want to talk a little bit more about men and men coming through the ER and some of the things that you see more frequently in men, the issues that they would come through the ER for. I'm gonna let you think about that for a second, because we're gonna take a commercial break here, and thank our sponsors. Talk about our sponsors for a minute. So today's show, very important show, is being brought to you by Inclusion Clubhouse. Inclusion Clubhouse, a 501c3 not-for-profit organization that provides social and recreational activities for those with different special needs and their siblings, while offering support to the family as a whole. They exist to create a space that is truly all-inclusive and accessible for children, teens, and young adults of all abilities. Inclusion Clubhouse will help create a more inclusive community. Inclusion Clubhouse will be hosting their annual Special Needs Family Prom on Saturday, July 21st, 2018. I will say that again. They will be hosting their annual Special Needs Family Prom on Saturday, July 21st, 2018. For more information, go to their website at www.inclusionclubhouse.org. Again, www.inclusionclubhouse.org. They will be hosting it at the Lowe's Hotel. You can get ticket information from their website. There's also a link on our website, table45.com, and you can get and donate through that link and buy your tickets. It's an excellent organization, and we look forward to their Special Needs Prom once again this year. So
We're back.
yes.
We are back. Now, I know they're saying, I thought this show was about men's health. I know it's not about me. It's just my little anxiety.
Men's health.
I know,
Let's get to
so-
some men. We talked about some men things, though.
I know. So what is the things that the difference between that you can say in men's health between a woman, and do men really take care of their health? And what are the things that they really should be looking at?
So, okay, so when I was trying to find some evidence-based stuff about like the differences between like men's presentation to the emergency departments, women's, I really couldn't find much. But there's, top reasons why people present to the emergency department. So chest pain, shortness of breath, abdominal pain. In regards to chest pain, the presentations from men and women are actually different. We have a problem with coronary artery disease in America because of diet, weight, things
Lack
like
of
that.
exercise,
So, I think classically, people say, if you have chest pain, it radiates to your arm, or if you have shortness of breath, come in. So with men, they do manifest cardiac chest pain like that. They have crushing chest pain or pressure, and it radiates to their arm sometimes. That's the way they present. So it's easier to pick up on cardiac chest pain in men. And you see it all the time, whereas women, they kind of have atypical presentations. So those things are easy. And then, everything else is pretty similar, the way you treat it, at least from an emergency medicine perspective. So shortness of breath, if you have, congestive heart failure, if you have asthma, if you have COPD, which is chronic obstructive lung disease, there's not really many differences in the way you treat men and women. But also interesting, what I found is there's not because there's not a lot of research, we don't really know if there's any value in treating them differently per se. At least I didn't find much when I was looking.
And then what about just in your experience, what have you seen? Like, do you feel like you see, because I feel like men tend to wait.
Oh, they do.
So do you see, will you see?
But they don't with chest pain though.
Right. Because everybody
No,
thinks
I'm
they're
serious.
having a heart attack.
No, but men come right away.
When
Women wait. And
Yes,
the reason they
for
wait
chest
is
pain,
because their pain, their symptoms for cardiac disease manifest different. It's like, oh, I feel a little tired. I'm a little nauseous.
We're conditioned to think of.
No, they just.
I think
just
the
a lot
other
of
ones.
people aren't trained to recognize those as symptoms of cardiac disease.
Right.
So would
The
you think-
physicians, or do you think the patients?
patients.
The patients, yeah.
So would you think that your nausea and your weakness is a heart attack?
Right. No. Because
Exactly.
because people. That's what I'm saying. We're not trained. We're
Right.
not conditioned. Women. We're not conditioned to understand that our symptoms are different than the men's symptoms.
Right. So men come. I would say chest pain is probably one of the main things that they come for right away. But I feel like other things, like things that are like a little bit less acuity, they wait. So oftentimes their wives make them come in. Like I'm like, well, why did you decide to come if this has been going on for a month?
Right.
My wife basically said I had to come.
To the emergency room instead of the doctor.
Right.
Right.
They do wait, so sometimes their symptoms are a little worse when they come in, or we pick up on things a little later. There's some data that shows that men who are married actually live longer because because their wives like force them to get care. Like anecdotally, like when I take care of the patients, like you ask the gentleman, why'd you come in today, and they're like, oh, I don't feel good, and they're very vague about their symptoms. And then their wives are like, but no, because this is what's really going on. So I feel like men just don't communicate what's going on with them very well. So sometimes that may make it a little bit more difficult to take care of them.
And I know we also talked a little bit too before the show about men not necessarily having a specific doctor. Like we have our primary care doctor. Everybody should have a really great and good primary care physician, which is also very, very, very hard to find, depending upon your insurance and your location and all this other kind of stuff. And I encourage people, if you can afford it, to not get an HMO, to get a PPO, because then you have the control in your hands to be able to contact a specialty physician, like a gastroenterologist or a dermatologist or an orthopedic surgeon or whatnot, what have you, even an oncologist if you feel it necessary, cardiologist, instead of waiting for those referrals. But getting back to it, I don't think
something. So sometimes people don't even know the difference between an HMO and a PPO. So they're both, manage medical care. An HMO, you kind of have limited options of who you can pick for your providers. You have to kind of go within your network. If you go outside of your network of providers, your insurance company won't pay for it. And oftentimes when you need to see a specialist, you have to get a referral from your primary care doctor. Whereas a PPO, they have more of a vast array of physicians that you can choose from. There are still some penalties if you go out of network. But
a question. So let's say someone comes into the ER and you work at a hospital. Does it matter what insurance they have, whether it's an HMO or a PPO in
that's
the ER?
a trick question. Isn't it?
Oh, I'm sorry.
So
you don't think about that in an emergency. You just want to go to the
well,
ER.
in an emergency, you're supposed to be able to be seen.
Well, okay. So there's
ER.
actually a law that it's called EMTALA. It's a law that I forgot what year it came about. But so hospitals used to do this thing called dumping because they didn't want to take the insurance that you had. They would, send them down the street to county or whatever because they were uninsured or they had like Medi-Cal or something like that. So now with the EMTALA law, you have to see any patient that steps onto the hospital property, no matter what insurance they have, no matter race, color, whatever.
Whether they have insurance or not.
Whether they have insurance or not. So you have to see them and do what we call a medical screening exam. And a medical screening exam is to make sure they have no life-threatening illness that makes them unstable. So that's EMTALA. So we have to see everyone. But this thing that we have here in California with health insurance, even if you have insurance and you come to an emergency department and you require admission, but let's say you're stable but you require admission, so I don't know, you're a little dehydrated and your sodium is low but not like dangerously low, and you need some IV fluids because you've had nausea and vomiting for a couple of days and you need admission. So let's just say you have an insurance company that has a contract with another hospital, and you're capitated to that hospital, you will be transferred to that hospital. You won't be staying at my hospital.
Oh, wow.
Unless you're unstable. So anybody with like chest pain with elevated troponin, that's an enzyme that kind of assesses your risk for cardiac chest pain, you would stay. If you have to go to the ICU, clearly you're not going to be transferred. Anything that we deem unstable, you would stay. But if you're like stable and you're getting admitted, if you're capitated to a different hospital, you're not staying at the hospital at the ER that you came in.
And that's in the state of California, or is that across the board?
So I
think
it's kind of, I think that's, I've only practiced in California, New Jersey, and Philadelphia. But I will say this: when I practiced in Philadelphia, I worked at an academic center, so we took everybody. I mean, that wasn't so much of an issue. But I will say, towards the end of my tenure in Philadelphia, we started to have care managers down in the emergency department basically saying, this patient doesn't meet criteria for admission, so you probably shouldn't admit them. So those things are probably coming down the pipeline for other states and, academic centers.
So getting back to it, since we have gynecologists, so we have your general practitioner, which everybody should really try to find a really good one, which we've already said it could be difficult, so you need to do a little work. We as women have a gynecologist, so it's like kind of like a backup. I always feel like I go to my primary care, but then there are issues that I can always talk about with my OBGYN. But for men, they don't have a specific doctor. Do you think do you think that we should just have a doctor just for penises? Like,
well, we do.
Urologist, but I mean, but that's it. But you can also, a female can also see a urologist too.
Yes.
And men typically aren't necessarily going to the urologist like all the time.
On an annual visit.
Right.
I mean,
and do you think that they should? Because I feel like men love their penises, but I don't think that they pay attention to them enough until something is wrong with them.
Well, so the reason that you see a gynecologist on a yearly basis is because you want to most often assess your risk for cervical cancer.
Right.
So, but even now, Pap smears, the recommendations have changed. We used to do them yearly. Now it's depending on your risk factors and how many normal Pap smears you've had every 3 years or every 5 years.
Right.
So you don't even necessarily have to see a gynecologist every year anymore.
Right.
So with men, it's like if you had, let's just say, a specialist for penis outside of a urologist, what would you really be screening for? What would be the point of the visit besides erectile dysfunction?
I would say just another physician to be able to look at them, talk with them, talk about their colon health, talk about everything.
Right.
But men aren't necessarily going to their primary care physicians.
But I don't think that. But I don't think that would change if you had just a specialist for men.
You don't think so?
No, because there's not anything necessarily specific. If you have a issue with your penis, you'd probably see a urologist. I mean, erectile dysfunction, that's a huge issue for men, and that can be
men are afraid of it too.
Yeah, and it happens more frequently than people think because we have such high rates of hypertension and diabetes, and those specific diseases definitely cause problems with erectile dysfunction. Men as young as like 40, you have a lot more life to live.
Yes.
And you have issues.
So let's talk about that too. Like, I think a lot of men are concerned about that, and so to me it just stems from that. You know what I'm saying? Like they love it so much that they need to understand that there are things that they need to be concerned about in their other health that could affect that, and they don't seem to care about it until they don't. I don't think that men in general, I'm speaking in generalities, I'm sorry, male population, but I feel like they don't get concerned until something goes wrong with that down.
But that is the nature of men, and I don't necessarily know that adding
How do we change
education. So that's the reason why I wanted to do this podcast, and I think that's just the problem with healthcare in general. There's such a disconnect between what the patients understand and what the physicians understand, and that even when you sit, even when I sit down and I spend 10 or 15 minutes in the emergency department, and that's a long time in emergency medicine time to spend 10 to 15 minutes talking to a patient about their results. I walk out of the room and they'll say to the nurse, "Oh, I don't know what's going on with why I'm here," and you're like, so sometimes I call you guys lay people. Your ability to understand medicine is sometimes not limited, but medicine it took me 12 years to fully understand it. So why would you understand it in a single setting?
Right.
So it's really just education, but that's why it's key to have a good primary care doctor, because those are the physicians that are supposed to, sit and talk to you and make sure you understand what's going on. So it's more, I feel like it has to be a shift in the thought process, not necessarily a specialist for men. But there's some men who are great at their healthcare and have a great understanding of what's going on with them. Like my brother, my God, I've never seen a man go to the doctor so much. Oops. And his response is, I have good health insurance. Why not?
Yeah. Well, if you do, then you
and
get
then
all
I feel like along the way, then you get educate yourself. So let's talk about erectile dysfunction. Can you say one more time, what are some other things, some other factors?
Yes. And I want to ask you also about breast cancer in men, which I think is really important.
Less than 1%.
Yeah.
that occurs in men.
I know,
with
but
breast cancer.
I wanted to go back to the fact that we do breast cancer screening all the time because it's required, right? So is that something that men should be doing? No.
It's so infrequent and uncommon. There's no recommendations that men should be screened for breast cancer.
So how does it manifest in them? How would they know?
A lot of the same symptoms.
Oh, okay.
A lump in your breast, discharge, in your breast, in your chest, discharge.
tissue.
Yeah.
So do they need to examine themselves like women do? Like, is it,
So, you
or
know,
is it something that just happens
it's
and you're like,
interesting,
oh.
you know, part of me struggles with the recommendations for self-breast exams by women, because a lot of times you'll see evidence that says don't do it because it leads to a lot of false
Negatives.
Yeah, you'll feel something that you think is abnormal, and you'll go through all this testing and it's nothing. But I also anecdotally, like, my mom found her breast cancer because she was doing a self-breast exam. So, you know, I don't know how to feel about that recommendation.
Yeah.
So, you know, same thing with men. If you feel something abnormal, or your chest is hurting more than it did, or you feel something strange, or your nipple looks weird, or you have something discharging from it, like, you should go get that checked out. The first thing you need to do is go to your primary care doctor. And I know, like, men kind of have this thing, I don't have any symptoms, why do I need to see a doctor? My father's like that. He's old school. Nothing wrong with me. Why do I need to see it? But every year, just go get checked up to make sure that there's nothing, because then what happens is you're 65 and you go to the doctor and you have hypertension, high cholesterol, COPD, heart failure. That happened to my dad. So
Oh my God.
All at once,
yeah,
kind of.
all at once. Thought
Yeah.
he was gonna die.
Yeah.
Oh my God. Was he symptomatic? Is that why he went? He just said,
so my dad for a long time was having he kept saying, I just keep getting dizzy, or keep getting this chest pain, and he just refused to go to the doctor. And then one day he got so dizzy he almost passed out, and that scared him. So he was like, he told my mom, I think I should go to the doctor. So he went, and that's when he got something called ventricular tachycardia. It's basically when the bottom part of your heart is just kind of going crazy. It's not beating it's beating really, really fast. And then the next phase after that is ventricular fibrillation, where it's just going crazy, and it's not able to sustain any form of circulation that's compatible with life. And so when you get that, you'll get dizzy and you will pass out. So he was having that, but he had a cardiomyopathy, which is, you know, dysfunction of your heart. And he had pretty severe cardiomyopathy where he was wearing a life vest for a while, and he almost got a defibrillator. So, I mean, things worked out. He started some medication, so he's better. But that's what I mean when men don't like to go
there's
to
no
the
maintenance.
There's no
The
maintenance.
importance
Yes.
of maintenance for
Right.
men's health. So
Yes.
is heart disease the number one concern in men's health?
In general, men and women. So heart disease, along with that, like cholesterol, cancer is up there. And then, you know,
What
we have
about
a lot
diabetes?
of diabetes is like at the top. So coronary artery disease, cardiovascular disease, diabetes, cancer, those are kind of probably in the top 10 of things that people should be concerned about. Diabetes is a huge issue too, and I think it's such an issue with non-compliance. Like, people just don't take their medications.
Really?
And, you know, so you got high blood pressure, diabetes, cardiovascular disease. Those are the big three. And oftentimes, you know, minorities, Hispanic, African American, even Native Americans, they have horrible rates of diabetes. You know, these are things that need to be dealt with, and that's why men need to see their primary care doctors, because they cause erectile dysfunction.
Yeah, and I was going to say, now, why do you think, or do you feel that in communities of minorities, particularly minority men, that they're not seeing physicians? Is it as for a specific reason? Do you think it's generational? Do you think that
It's
either
just
in
being
the
a man?
ER or in even like a general practitioner setting, do you think men of color aren't either taken seriously or not really? I feel like they're not cared for in the same level.
I think that's multifactorial. A lot of the things that you just said, generational in the sense that there's still a huge distrust in medicine amongst people of color. Because of things like Tuskegee Airmen. There have been like
and nobody talks about that.
Nobody talks about it. I read a book, what was it, Medical Apartheid? I think that's what it was called.
Well, just the Henrietta Lacks story opened my eyes.
But the things that they used to do with like gynecological procedures with women with no anesthesia, when they had anesthesia available, like those things make minorities distrust medicine. So there's a huge hurdle to, overcome that part to get people just to come in and trust what their doctors are saying. And it's weird because the older generations, I feel like, are more like, yes, doctor, yes, doctor, yes, doctor. And they'll kind of sort of do what you say. The newer generation, they don't trust anything they would say. They're Dr. Googles.
Oh, I like that, Dr. Googles.
They come in with their own thought process. And it's like, Google, and they have great resources, and they supplement what we tell you, but you can't replace 12 years of training. Right. You just can't. I mean, and there's good doctors and there's bad doctors. I'll give people that, but you have to trust us. That's why I kind of like to have these platforms like, trust us. We're trying to help you.
Yeah.
So.
But also too, I think people need to try to educate themselves. They need to be able to go in and ask good questions so that they can fully understand the information that you're giving them too.
The biggest thing that I tell people to do is, because you're at home, right? And you're like, I'm going to go to the doctor. I want to ask them this. I have these questions. And then what happens when you get there?
You forget.
Write them all
down. What I tell people all the time, write down your questions. And if the doctor's talking too fast, say, hey, can you slow down? I want to write this down. Yeah. And the way physicians schedule time is usually like 15-minute time slots. Demand your time. Don't be rushed. This is your healthcare. They may be a little annoyed. Oh, well, ask your questions.
Yeah. And I would say get an advocate. So for those of us who have men in our lives, get the men in your lives to the doctor annually. And men out there, or people who just in general feel uncomfortable with going to the doctor, bring someone with you. Bring someone that you trust with you. Bring an advocate with you. I don't think it would be bad.
One thing we didn't address with men's health is prostate cancer, because that's unique to men.
We got 5 minutes.
Unique to men.
Got it. Let me speak through this. Hold on. Where is it? So some symptoms of prostate cancer: urinary complaints. So you can't pee, your stream is not as strong as it was. Urinary retention, like you literally can't pee and your belly is hurting. Back pain, or something called hematuria, where there's blood in your urine. Now, those can be symptoms of prostate cancer, but also just BPH, which is benign prostatic hypertrophy, hyperplasia. So, those can be similar, but you should still get those checked out. There's recommendations for screening for prostate cancer, which is where they either do a digital rectal exam or they do a PSA, which is a prostate-specific antigen level.
Is that a blood test?
Yeah.
Okay.
So those levels can help indicate your risk factors for having prostate cancer. So levels greater than 10 usually is like, ooh, you probably have cancer. Less than that, it's kind of like, eh. So the definitive diagnosis for that is a biopsy. So usually they recommend screening for that around age 50, but that should be in conjunction with the discussion with your primary care doctor. Hence, you need to get a primary care doctor.
Yes. And also to family history, right? Because if you have a good, primary care physician, I don't necessarily love to go by the numbers. Just because you're not 50 or whatever, you should talk to it. And I'd say 35, 40.
Right. Yeah. So with any preventative screening exam, there's always deeper levels of the recommendation. So when you have relatives with first degree relatives with some of these diseases, they do recommend early screening. So if you've had like a relative with prostate cancer who's less than 60 or 50, you start screening 10 years before. The same thing with colorectal cancer. If you've had someone who's had colorectal cancer less than the age of 50, you start screening 10 years before. And there's certain familial syndromes with colon cancer, and then also ulcerative colitis or Crohn's disease. Yeah. Those people start getting screened way earlier because they have higher risk of
And
cancer.
people don't really talk about Crohn's disease a lot either.
It's painful.
Yeah, but they don't talk about it. Now, what are your thoughts on getting baselines? Because I'm a
baselines of what?
Baselines of any baseline blood tests of whatever hormones and stuff like that. Because I feel like in the next 2 years, I've got 2 teenage boys at home, and I would say in the next year or two, before their hormones get too far out of whack, because they're not like super into puberty, I'm just going to request a baseline blood test, because I feel like the earlier you have a baseline, the more that you can check and see how your body is changing.
So you
don't have to start in teenager puberty, but I feel like someone in their early 20s, I think you should get a baseline blood test for a whole bunch of tests.
So that depends on what you're looking for.
I'm like looking for everything.
The thing with medicine is, or anything, right? So like if you start looking through stuff, like let's just make this as simple as you're a girl and you're looking through a dude's phone. You're going to find something that you think is suspect, but you don't know the context to it. So you start looking for stuff for what reason? You're going to find something, but then it's like, well, what does that mean? So I don't necessarily agree with doing baseline stuff when you don't have a reason for it, because you're going to find something that's abnormal. Our bodies fluctuate with our
Right.
hormones.
Well, just so I can feel like, because for me, my levels of everything have always been different, and my thing is, okay, well, you're fine as far as the whole general level, but it's not been okay for my particular body. So I feel like it has aided and assisted, and it can aid you and assist you in understanding your particular body. And I wouldn't be alarmed, like, oh my God. And there are things that are going to be off, and sure, and I think you need to take that into consideration. But I think just to have something
but I think so. Okay, so
to build off of.
It's so difficult to say in young people because usually you have nothing wrong with you. But if you have a strong family history of really high cholesterol, is it better to start checking your cholesterol early? Yeah. With females, like your hemoglobin, if you have really heavy periods or you have history of fibroids and things like that, yeah, it's good to have a baseline. But you're looking for something in specific. Like you have to tell me specifically what you mean. Check for what in your young boys?
I want to say check for everything.
The only thing I recommend checking for young boys is HPV. That's it.
HPV.
And you can do that through a blood test.
I don't know how they do it in boys. I know with women they do like the cervical, like the speculum exam.
I think with boys it's a blood test.
I think they just and they do a vaccine.
pediatrics
And we had a
office,
whole other discussion that I wanted to talk to you about the HPV vaccine in boys and your thoughts. So we're going to have you back. 'Cause we are out of time.
Yes. Oh
We are
my
out of
gosh. And
time.
this is so much. Look, everybody's like,
Yes.
thumbs up on this conversation.
I would say the takeaway is all men, you need to be concerned about your health.
primary physician.
Get a good primary
Absolutely.
care physician. Don't
Good
wait
job,
until
Robert Mata.
it's too late.
Shout out to
Because you don't
Robert.
want to be necessarily in the ER all the time.
No.
But if you have questions and you feel like you don't have anywhere to go,
Come see
please
Dr.
come.
Kelly.
We're
Yeah.
here.
Yeah. Go, or should have.
The best time is 3 a.m. to 5 a.m. There's no one in there.
Oh,
Come see Dr.
There's
Kelly.
a little tip for your ER run. If you're going to
Thank you
get sick, do it from that window.
Yes, yes. This was amazing. Thank you
Yes,
so
I'm
much
like,
for taking the
you're
time.
welcome.
out to
I
say
appreciate
so
the
much
invite.
information.
This
Oh
was
my
fun. I'm a
gosh.
little less nervous now.
No, you good.
I hope I didn't say anything that was wrong. All the physicians are very critical. If you're a physician, I'm not perfect. Okay.
No, this was so great.
Listen, you did us a great service.
We want to thank Dr. Kelly for joining us this Monday. We hope you've been informed, educated, and I'm sure you've been informed, educated, and slightly entertained.
Yes.
We'll catch you next Monday live here on LA Talk Radio. Thank you for watching. Have a great rest of
Have
your
a great week. Bye.
It was fun.
You're listening to Table for Five with Felicia and Annette, only on LA Talk Radio.